good morning, everyone. We are starting with the new lecture topic, that is cancer-induced venous thrombosis. A lot of time you will find this patients with venous thrombosis and how we can handle this situation. Dr. Gayatri and Arjun, their resident, will speak about that what exactly we should do and how to manage this. I request Dr. Gayatri to introduce Arjun. And I think Gayatri ko we don't need introduction. Gayatri, I think everybody knows you. She's a most important and very renowned palliative care physician in India as well as abroad. So we can start with the with the request, Dr. Gayatri, that you can introduce Arjun and start the topic. Thank you very much.
Thank you, Dr. Sushma, and very good morning to all of you once again. And I with pleasure introduce my colleague, Dr. Arjun M. Pillai, who is a second year resident DNB in palliative medicine, working with me in MNJ Cancer Hospital, which is a regional cancer center in Hyderabad. And without wasting much time, Arjun, over to you. So I request all of you, please, you can, whenever there's a questions or thoughts or reflections, or you're sharing your experience, please put it down on the chat. We can take it at the end of the session. And welcome all of you. Over to you, Arjun.
Thank you, ma'am. I'll just share my screen. Is my screen visible actually?
Yes, we can see it. Thank you, Dr. Arjun.
So very good morning to all of you. So today I will be talking about session of cancer-induced venous thrombosis. So first I'll just start with a case. So this was a 53-year-old man who was diagnosed with CA lung with bone mets, and the bone mets was in his right acetabulum. And he had undergone his full 10 fractions of palliative RT and was on his palliative CT. It was given 10 days back. And he was also on zoledronic acid, who came to us with a complaint of severe pain in his right lower limb, which was a continuous in nature and distending type of pain. And he scored it out of 6 out of 10 actually. And there wasn't any other associated symptoms for this patient. The reason why I selected this case was that this is one of the most common presentations of patients with venous thrombosis that comes to us in our OPD or an IP practice as such. And most of the time we might miss this diagnosis and feel like it might be due to a bone lesion as such. For this patient, initially after starting with the analysis, there wasn't any significant pain relief, and on doing a Doppler scan, he was found to have deep vein thrombosis. So basic introduction of the topic. So cancer-associated thrombotic events are a major cause of mortality in cancer patients. These thrombotic complications in cancer can vary from both arterial, venous, or disseminated intravascular coagulation sizes. And the reason why which cancer patients are at a higher risk of developing a thrombotic event is that cancer itself is an hypercoagulable state, which is one of the risk factors of a thrombotic event. Other than that, multiple risk factors also rise in cancer patients, these being prolonged immobility and chemotherapy drugs or surgery, which in turn add on the risk factors for a thromboembolic event and make them much more prone for a thrombotic event. And of the various thrombotic complications in cancer, venous thromboembolism is one of the most common complications, and the association between cancer and venous thromboembolism has been recognized for over 160 years. And when you put it into a statistical point of view, almost 20% of all cases of venous thromboembolism occurs in patients with cancer. And in cancer patients, about 20% of them have an episode of venous thromboembolism before their death also. So when we see about the venous thromboembolic event, we actually consider two terms. One is the deep vein thrombosis and other is pulmonary embolism. I believe all of us must have encountered multiple patients who are at least suffer any one of them, either deep vein thrombosis or pulmonary embolism. So initially, a vascular thromboembolic event was considered of limited relevance to a palliative care team. There were multiple factors for this. One was the challenge in diagnosing a VTE in a patient with cancer, and other was about the management of a vascular thromboembolic event. The reason being, most of the time when we diagnose a vascular thromboembolic event, we find it challenging to manage it in our palliative care unit as such, and we might consider shifting the patient to the parent unit or medical oncology unit for some time, which in turn feels will affect the care of the patient. And most of the time, what happens is the symptoms associated with the DVT or pulmonary embolism is readily attributed to other pathologies which are seen in advanced cancer. These symptoms can be edema, breathlessness, syncope, or pain as such. And most of the time, we consider it as a symptom of the disease progression or such, or other confounding factors of the malignancy. I'll be talking about the confounding factors of the malignancy later. However, recently, due to the advancement in cancer care in the past 1 decade, it has resulted in increased lifespan of patients with cancer. And as a result, as a patient is surviving for a longer time, and the treatment also being continued for a long time, the risk factors are also persisting as such from much greater duration. And this has led to an increase in incidence of cancer-associated vascular thromboembolic events. So, a vascular thromboembolic event not only affects the physical and economical aspect of the patient, but also has a significant effect on the quality of life of the patient. We, as palliative care physicians, always strive to improve the quality of life of both the patient as well as the caregivers. And a VT event always significantly affects the quality of life of the patient. And multiple researchers has been conducted in this field, and the major common theme which came out of that was that patients consider an experience of a DVT or pulmonary embolism more distressing than the initial cancer diagnosis as such. There are multiple factors for this. One can be the symptom, the physical symptom that they experience with the DVT or pulmonary embolism as such, like breathlessness, pain, edema. This is causing a significant stress for the patient as caregiver. The other factor is that 50% of these thrombotic events usually occur within the initial 3 months of the diagnosis. And the patients who are already coping with a severe already coping up with the diagnosis of cancer, so find it extremely distressing, and they view this thrombotic event as a severity of the condition as well as a poor prognostic sign. And the reason behind which why the thrombotic event occurs within the first 3 months of diagnosis is that usually after the diagnosis, patients are started on chemo or any surgical intervention during the initial period itself. And these are multiple risk factors which aggravate the risk of having a thrombotic event. Other thing which causes significant affects their quality of life is the lack of information or supports which both the patient and caregivers receive when they are diagnosed with a vascular thrombotic event. Most of the time, even when we diagnose a VT, not only we, but the primary treating team won't disclose further information to the patient or the caregivers, telling them why this happened and what is the reason behind it and what is the treatment plan for the same. This in turn also further causes stress to the patient or the caregivers because they were not aware of what is happening to them and what is the treatment plan for the same. Now, with regards to risk factor, I have categorized into 3 categories. One is the individual patient risk factors, other is a cancer-induced risk factor, and that's the cancer treatment-related risk factors. So we'll start with the individual patient risk factors. So with individual patient risk factor, the first risk factor is age. As you're all aware, with the increase in age, the risk of developing a thrombotic event is also rising exponentially. And this risk is also attributed with chemotherapy and surgical intervention. What that means is that in a patient who is more than 60 years of age, starting him on a chemotherapy or a plan for a surgery, the risk of him developing a thrombotic event is much more higher than a patient with a similar diagnosis is much more younger in age. Also, another thing which has been found out was that patients who are much more, like more than 60 years of age, have higher risk of developing a vascular thrombotic event rather than a non-cancer patient without a similar age group. Now, regarding the differences in risk factor with regards to sex, females are found to have a greater risk of developing a venous thromboembolic event. However, males have a higher risk of developing arterial thromboembolic event. While with regards to race, people belonging to black racial group, whites or Hispanics are a higher risk factor of developing a vascular thrombotic event. Now, comorbidities like renal failure, respiratory disease, heart disease, obesity, and acute infection also contributes for this risk factor. And immobility itself is a high risk factor for developing a vascular thrombotic event. And what research has found out that an immobility of just 3 days itself increases the risk of developing a venous thromboembolic event exponentially. And patients who are suffering from who had a previous history of a VT have much more higher risk of developing recurrent episodes for venous thromboembolic event. Now, with regards to cancer-associated risk factor, the site, stage, histology, and time of the diagnosis are the common risk factors which we find, which aggravate the event of a venous thrombotic event. With regards to site of cancer, a malignancy in pancreas, uterus, lung, stomach, kidney, or primary brain tumors are found to have much more higher risk of developing a venous thrombotic event. Of this, pancreas is the one which is found to have a much more higher risk factor. And stage of the disease, patients who are in more of the advanced stage of disease or having distant metastasis are having much more higher risk factor of developing a venous thrombotic event rather than patients who are in the initial stage itself. And with regards to histology of cancer, this again is really much more, the researchers are going on in this field, but the data which we have right now is just limited to pancreatic and GI cancers, of which what data has found out was that adenocarcinoma is having slightly higher risk of developing a thrombotic event compared to other modes of histological forms of cancer. And with regards to time after diagnosis, the initial 6 months, like 3 to 6 months, are the time period in which people or patients are having much more higher risk of developing cancer. This is because of the initiation of chemotherapy, which itself is a risk factor, or planning for surgery, which and immobility associated with the same, which further aggravates the risk of developing cancer. Now, with regards to the cancer treatment associated risk factors, these are surgery and hospitalization. Sorry. Chemotherapy. Certain chemotherapeutic agents like cisplatin, L-asparaginase, thalidomide, lenalidomide, and tamoxifen can also aggravate risk of developing venous thrombotic event by itself. I will explain the mechanism behind this in later on. And recently, angiogenesis inhibitors like bevacizumab has been utilized for cancer treatment as such. The risk factor behind angiogenesis inhibitors is that the mechanism behind it is that these inhibitors activate our endothelium, and on due activation of our endothelium, there is higher risk factor of developing an arterial thrombolytic event. Even though the venous thrombotic risk is there, much more risk is found in arterial thromboembolic events with angiogenesis inhibitors. And central venous catheters are more commonly used in cancer patients for delivery of drugs and collection of blood samples. These in themselves are a high risk of developing a thrombotic event and can form due to microthrombi as such. Now, with regards to the pathophysiology, a simple way to understand the pathophysiology is by understanding the Witcher's triad, which is stasis of blood flow, endothelial dysfunction, and hypercoagulability. Any factor which contributes the following three, the above mentioned three, can result in a venous thrombotic event. So, with regard to hypercoagulability, as we are all aware of, cancer itself is an hypercoagulable state. And this is due to the direct and indirect release of procoagulants like tissue factor and as well as inflammatory mediators. With regards to the mechanism of development of cancer-associated thrombosis, even though complete mechanism is not clear, we have got two pathways. One is the direct mechanism and other is the indirect mechanism. So in direct mechanism, there are multiple factors. I'll be briefly talk about each factor actually. So regarding tissue factors are tumor-derived procoagulant protein. These inhibit the extrinsic pathway and cause thrombus formation. Microparticles are released from the cancer cells. They have got a role in both the direct mechanism as well as the indirect mechanism. Via the direct mechanism, they accelerate the thrombus formation. They also have express surface tissue factors, which in turn is a stimulus procoagulation. With regards to podoplanin causes activation and aggregations of platelets, and it's in turn promotes thrombus formation. And plasminogen activator inhibitor, like the name suggests, by inhibition of plasminogen, in turn inhibits fibrinolysis, which in turn promotes thrombus formation. Cancer procoagulants directly activates the factor 10 and stimulates the coagulation pathway. And tumor-derived platelet agonists are there, like ADP and thrombin, which causes platelet activation and aggregation. So this is the mechanism of this is the chart which shows the direct mechanism, in which we can see the tissue factor, plasminogen activation inhibitor, cancer particle, and podoplanin all inhibits fibrinolysis and results in formation of thrombosis. Now, with regard to indirect mechanism, like I mentioned earlier, microparticles is released by cancer cells, but sometimes it's also released from the activated endothelial cells and monocytes in response to cancer. This in turn stimulates the coagulation pathway and causes thrombosis. And in our body, sometimes inflammatory cytokines like TNF alpha and interleukin 1 beta are also stimulated, which are procoagulant in nature and stimulates thrombus formation. Adhesion molecules promote the attachment of particles to endothelial cells, and which in turn can cause formation of thrombus. Then there is neutrophil extracellular traps. Mucins are also produced sometimes, which forms microthrombi. And cancer itself or tumor itself can cause hypoxia, which in turn promotes an endothelial dysfunction. And other factors are damage associated molecular patterns, coagulation gene defects, and decreased coagulation inhibitors. With regards to cancer associated chemotherapy, the mechanism of cancer associated chemotherapy through which it induces thrombotic events is that we can say it as a threefold mechanism. One is that these chemotherapeutic agents, drugs, can directly cause injury to the endothelium, and this in turn causes formation of thrombosis. The other mechanism is that these chemotherapeutic agents sometimes may trigger the monocytes to uh, show more expression of tissue factors in the cells, which, as I mentioned earlier, tissue factor itself is a procoagulant, and it in turn can stimulate thrombotic events. And other mechanism is by hepatotoxicity of by chemotherapeutic agent, which in turn decreases the production of anticoagulants like protein C, S, and antithrombin. All this in turn can increase the risk factor of thrombotic event. So this is the schematic diagram which shows the indirect mechanism of a thrombotic event. So with regard to the clinical features, based on the thrombotic event, like if it's a DVT, the patient may present to us with severe pain, erythema, and swelling of the lower limb as such. And sometimes in pulmonary edema, pulmonary embolism, the patient can present with dyspnea, hemoptysis, or syncope. And the investigations which is done worldwide and is considered gold standard for a vascular thrombotic event is Doppler ultrasound and a CT pulmonary angiography. However, most of the time, the patients, whenever they present a symptom of pain, edema, or dyspnea, there are other confounding factors which are present in cancer patients. These are anemia, pneumonia, pleural effusion, heart failure, pulmonary metastasis, cellulitis, hypoalbuminemia, and lymphedema. Most of the time, what happens in our practice is that whenever a patient presents with shortness of breath and edema, we consider all these factors to be the reason behind the same, and we don't go for an aggressive management of a vascular thrombotic event as such. And once we rule out this diagnosis, then only we consider of a vascular event or a venous thromboembolic event as such. So, with regard to the management of a venous thromboembolism, we can consider pharmacological prophylactic and treatment option, which consists of unfractionated heparin, low molecular weight heparin, vitamin K antagonists like warfarin, and directly orally acting anticoagulants. And most of the time, there's a dilemma regarding the prophylaxis treatment with patients who are having a venous thromboembolic event. The reason behind is that we must always balance the risk of a venous thromboembolic event and its recurrence with the increased risk of bleeding. Most of the patients who we see in our OPD, generally cancer patients themselves have got an increased risk of bleeding. So always the treatment option and prophylactic option must consider both the risk of a recurrent venous thromboembolic event as well as the increased risk of bleeding. And one thing most all of the guidelines say is that we must always consider an anticoagulant that does not interfere with the cancer treatment and has the best efficacy or safety profile, rather than considering an anticoagulant which can be administered orally. This is one of these two are the major points which we must consider whenever we are starting an oral anticoagulant or an anticoagulant for the patient who is diagnosed with a venous thromboembolic event or who has had a higher risk of developing. So this is the coagulation pathway. There's an intrinsic pathway, extrinsic pathway, and the final common pathway. I won't be going detailed regarding the same. I just mentioned it for a better understanding of the mechanisms and the mechanism in which the drugs are going to act. So with regard to the medications, I'll have briefly mentioned about 3 medications which we commonly use. So I'll start with warfarin. Warfarin is the most commonly prescribed anticoagulation agent for cancer-associated thrombosis worldwide. And its mechanism of action is that it interferes with the synthesis of vitamin K dependent clotting factors like clotting factor 2, 10, 9, and 7. However, warfarin itself has got a significant drug-to-drug interaction, and it itself is associated with increased risk of recurrent thrombosis and bleeding. Heparin is another drug which was used for management cancer-associated thrombosis, and its mechanism of action is that it activates plasma antithrombin 3 and it inhibits both factor 10A and factor 2A. So it binds to both the clotting factors, intrinsic pathway and a common pathway. However, heparin, similar to warfarin, has got its own set of adverse effects, and most common adverse effects being bleeding, hypersensitivity, heparin-induced thrombocytopenia, and osteoporosis. Nowadays, what we use commonly are low molecular weight heparin. These include dalteparin, enoxaparin, tinzaparin. These are the drug of choice for treatment of cancer-associated thrombosis. And their mechanism of action is that they selectively inhibit factor 10A with little effect on 2A. As you can see in the figure itself, heparin inhibits both factor 10A and 2A, but low molecular weight heparin just inhibits factor 10A. So the adverse effect profile is comparatively less compared to heparin. And all these three agents, dalteparin, enoxaparin, tinzaparin, are available in our country. With regards to directly acting oral anticoagulants, these are dabigatran, rivaroxaban, apixaban, and edoxaban. So dabigatran is a direct thrombin inhibitor, while apixaban is a 10A inhibitor. And all these four drugs, dabigatran, edoxaban, apixaban, and rivaroxaban, all these are available in our country right. I will just briefly mention about IVC filters as such. The role of IVC filters in prevention of venous thrombosis embolytic event is still controversial as such. There are certain beneficial effects, but also there are certain adverse effects as such. And though the role of IVC filters is more important to primary treating oncologists, as palliative care physician, we must have a basic idea of the same. Like what are the absolute indications and what are the common side effects with an IVC filters. So the absolute indications of an IVC filters are contraindication to anticoagulation, complication of anticoagulation, inability to achieve or maintain a therapeutic anticoagulation, or recurrent venous thromboembolic events while on a therapeutic range of anticoagulation. While the relative indications are massive pulmonary embolism, limited cardiopulmonary reserve, free-floating IVC thrombus, and poor compliance with anticoagulation therapy. Well, like I mentioned earlier, there are multiple complications associated with an IVC filter, and these are improper anatomical placement of the filter, migration, angulation of filter, caval stenosis, occlusion, and embolism. So most of the time, whenever we consider a patient or IVC filter, we must always weigh the benefits as well as the complications. And one thing which we need to consider is that an IVC filter is usually preferred for a massive thrombus rather than a microthrombus as such. Now, regarding thromboprophylaxis, there are two forms of thromboprophylaxis. One is mechanical prophylaxis, other is pharmacological prophylaxis. In mechanical prophylaxis, there are two forms. One is anti-embolism stockings and pneumatic compression pumps. With regards to anti-embolism stockings, it has been found useful for patients who have undergone surgery. However, multiple researchers regarding anti-embolism stockings have found out that these worsen the quality of life and is associated with significant discomfort for the patients, like ulceration, strain, stress, and all. So most of the time in palliative care, we don't prefer patients to be put on anti-embolism stocking as it in turn worsens their quality of life. Intermittent pneumatic compression devices can be considered for patients, and these are found to be highly effective in frail medical patients. And these are the standard prophylaxis in stocking. However, regarding the effectiveness of both these mechanical prophylactic measures in a palliative care setting hasn't been found out. Further researches hasn't been conducted in this field. And we can also consider the role of physical therapists in a venous thromboembolic event. And general guidelines which has been found out that they play a massive role in identifying patients who are at a high risk of developing a venous thromboembolic event. And they can help in preventing these events by promoting ambulation and providing exercises for these patients. And not only people who are at higher risk of a venous thromboembolic event, patients who are diagnosed with a lower extremity DVT, once their medications are reached a therapeutic level or an acceptable time period has been reached, mobilization should begin in these patients so that their risk of developing further events are much more reduced. And physiotherapists can also provide proper education and mechanical compression exercises to decrease complications with the venous thromboembolic event in general people, not only in cancer but also in general populations. Now, with regard to pharmacological prophylaxis, if there's an absence of contraindications in patient, 5-minute prophylaxis is recommended for an acutely ill hospitalized patient. However, what has been found is that very few specialized palliative care units worldwide have an hospital-acquired thrombosis prevention policy or plans. And only in certain countries, like in UK, there are certain policies and thrombotic events are like anticoagulants are administered for patients. Most of the time, when a patient is admitted in our palliative care setting, we rarely start or continue a low molecular weight heparin. And the reason behind is that majority of the palliative care patients who we see have significant contraindications to thromboprophylaxis or have an increased bleeding risk. And the other thing is that there hasn't been most of the guidelines or research which has been conducted regarding the management of management of a vascular thromboembolic event or thromboprophylaxis exclude patients who are having a very poor performance status for an ECOG 4 or PPS of 40 or less, or a bedbound as such. As such, there isn't a clarity or clear-cut guidelines regarding how to manage these patients. So this is the American Society of Hematology 2021 guidelines for management of venous thromboembolisms. There are 34 recommendations as such. I won't be cliently going through all 34 recommendations, just condense them into say. So what these guidelines suggest is how to manage a patient based on different scenarios in which they present. So if it's a hospitalized medical patient who is diagnosed with cancer, it's suggested that they must be started on thromboprophylaxis and a low molecular weight heparin must be considered over unfractionated. If it's a patient without a venous thromboembolic event, then pharmacological thromboprophylaxis is usually preferred over mechanical thromboprophylaxis or a combination of both pharmacological and mechanical thromboprophylaxis. And most of the time, it is suggested that we must discontinue the thromboprophylaxis at the time of hospital discharge rather than continuing them beyond a discharge date. This is for a hospitalized medical patient. Now, in patients who are undergoing a surgical procedure who are at a low risk of bleeding, it's suggested that a pharmacological measure is started for them rather than a mechanical measure. And those patients who are at the higher risk of bleeding, the guidelines suggest that we use a mechanical measure rather than a pharmacological thromboprophylaxis. However, like I mentioned, cancer patients are at a higher risk of bleeding as well as thrombosis. So those patients who are at a high risk of thrombosis, with an exception of high bleeding risk, for them a combination of both mechanical and pharmacological thromboprophylaxis can be considered. And low molecular weight heparin or fondaparinux is the preferred drug of choice. And it is always considered post-operative prophylaxis is considered over pre-operative one. And when it comes to abdominal or pelvic surgical procedure, we must continue the pharmacological thromboprophylaxis post-discharge of such. And for ambulatory patients with cancer who are at a low risk of developing thrombosis, no thromboprophylaxis are needed. And patients who are with an intermediate risk of developing a thrombotic event, for them, no prophylaxis is suggested actually. However, patients who are at a higher risk of developing a thrombotic event, parenteral thromboprophylaxis can be considered for these patients. And patients with cancer and a venous thromboembolic event, directly acting oral anticoagulant agents or a low molecular weight heparin can be used for the initial treatment. In cases where directly acting oral anticoagulant agents are not used, low molecular weight heparin is preferred over an unfractionated heparin. And for the short-term treatment of a venous thromboembolic event, that is from the initial first 3 to 6 months, a directly acting oral anticoagulant agent is preferred over a low molecular weight heparin. And patients with cancer who are suspected of incidental pulmonary embolism or SSP, the short-term anticoagulation is considered. While for who are on a CVC-related venous thromboembolic event receiving anticoagulants, it is suggested that we must keep the CVC intact. And with recurrent VTE, who are despite receiving therapeutic low molecular weight heparin, what we do is that we must hike the dose of low molecular weight heparin to supratherapeutic level. And if they're having recurrent venous thromboembolic event, it's suggested that we do not, even after anticoagulation treatment, we need not use IVC filters. And for long-term treatment of patients with active cancer and venous thromboembolic event, long-term anticoagulation is preferred over secondary prophylaxis. And we must continue indefinite anticoagulation over stopping of completion of a definite period of anticoagulation. And here again, the drug preferred is directly acting oral anticoagulant agents over low molecular weight. With regards to anticoagulation in last days of life, like I mentioned earlier, very little research has been conducted in regards to anticoagulation in last days of life, regarding any guidelines on how to manage these patients. And as we are all aware, cancer patients are extremely highly at a high risk of developing thrombotic even at their end of life situation. But we have little to no evidence regarding how to manage this with regard to anticoagulation. So what is generally considered is that the risk of bleeding in these patients who are at their end of life is higher than the risk of a recurrent or symptomatic venous thromboembolic event. And since the risk of bleeding is high, it is preferred that instead of starting an anticoagulation for patients who are in end of life, we can manage the symptoms of a venous thromboembolism with the standard end of life medications like opioids, benzodiazepines, as such. And their symptoms and suffering can be controlled with these medications. It can in turn improve the quality of life. And whenever a patient is on anticoagulant and he's on end of life, the decision to cease anticoagulation should always involve a discussion with the patient as well as a family member whenever possible, rather than stopping it from by our side uh, without consulting patients. So to wind up, this is one of the statement which I found in the Oxford textbook of palliative medicine research, and I found it interesting. That's why I kept it. So palliative care medicine as such does not aim to prolong life. Even though we improve, it has been found out that we prolong life. It's our major aim is to improve the quality of life. But likewise, we do not aim to shorten life. The reason that this is the most of the time when the patient is at a higher risk of developing a thrombotic event, we there's a general consensus that it's better that a patient just have a pulmonary embolism and pass away rather than suffer through the entire disease of cancer as such. But however, multiple researchers has been found that this event, like a pulmonary embolic event, is itself a highly distressful and significantly affects the quality of life of the patient. So we did not hasten the death of the patient by preventing required medication, but our aim is to improve the quality of life. So these are the references which I used for this presentation. One is regarding the Oxford textbook of palliative medicine, 6th edition. That is the essential of medical pharmacology. And I also went through 3 research articles. One is cancer associated thrombosis, an overview of mechanism, risk factor, and treatment. The American Society of Hematology 2020 guidelines for the management of venous thromboembolism, prevention and treatment in patients with cancer, and role of physical therapists in management of individuals at risk for a diagnosis with venous thromboembolism. Thank you. The presentation.
Thank you, Arjun. You can stop sharing screen. Yeah, thank you. We have ample time to take further discussion. Just to set the ball rolling, just want to summarize what Arjun has presented. Within 3 months of cancer diagnosis, patients are at high risk for developing venous thrombosis. That's what they found. They say 50% of deep vein thrombosis happen in the first 3 months of their cancer journey. And we have all patients with abdominal pelvic malignancies, they're absolutely at high risk for DVT. And the impact, this is very significant because the first 3 months is a very critical time and the patient is still dealing with the diagnosis of cancer. And then you tell them about DVT and that risk it carries. So they live with such extreme fear, which is such an emotional impact, other than the physical symptoms which they experience and the financial implications. So we underestimate the impact it has most of the time on the patient. And very often they don't get clear information. So they read and they get very terrifying information from the net and they live with that fear. So they need a lot of support during that time. And during cancer treatment, there's enough clear guideline. I request Arjun to share with Archana and Nisha, the American Association of Hematology guidelines, so that we can look at it. It's a ready reference during cancer treatment. And for palliative care, unfortunately, we don't have much evidence in what's there. Most of the research are on relatively healthy patients. So, but the general consensus is that quality of life versus and the impact it may have on the patient. And most of it's all the evidence is inclined towards using low molecular weight heparin and direct oral anticoagulant over warfarin and unfractionated heparin. But when they say that when there's a acute renal injury or renal failure, it's better to go for conventional heparin and warfarin, much safer, they say. So I open the chat for or forum for discussion, and I really invite all the senior faculty to share their own experience so that we juniors can also learn from them. Thank you. So there's a chat question about the use of analgesics in lower limb DVT patients with pain on best supportive care. Arjun, would you like to start telling us what you think about the use of analgesics in such patients, those who have DVT in extremely painful situation?
Thank you. So most of the time, it's dependent on what nature of pain it is and what kind of pain it is. Most of the patients who are in a best supportive care, they will be on an opioid coverage asset. Most of the time, morphine or handle methadone sometimes. So we can consider hiking the dosage of these medications, and also we can consider adding paracetamol or NSAIDs if the other blood parameters are within normal range actually for managing these patients.
Thank you. So there's something called post-thrombotic thrombotic syndrome. So I saw this terminology, but I'm sure we see this every day. It's about patients who have developed deep vein thrombosis, and the follow-up after like 6 weeks, it gets organized, and the limb become very swollen, and the skin become very thick and hardened, and the thrombosis really organized, and they develop huge swelling of the leg and lymphedema and venous and lymphedema combination, and they live with that disability, and which is very troublesome for the patient. It's not just the pain, and they live with a lot of heaviness and immobility, and so that adds to distress to the patient. And that's the kind of patients we see in our practice. Already they have developed thrombosis and they come out of it, but it's organized, and they live with that very bad limb with a lot of disability. That's another thing we have to consider, along with the acute phase when they have a lot of pain. And as Arjun mentioned, we have to use opioids. And I don't think this, unless we have any renal parameter worry, morphine is quite all right to use. There's no reason why we can't use opioids. I'll be wary of using NSAIDs if blood parameters are not all right. But yes, if there's inflammation, NSAIDs may be useful. But yes, we can use opioids. Thank you. Any questions? So I see Stanley sir with us today, joining the discussion, and he has immense experience as a physician and as a palliative care physician both. So sir, would you like to tell us something about your own experience?
Yeah, thank you, Gayatri, and thank you, Arjun. It was a very nice coverage. This is a very difficult area, and unless we have definite policy, it is very difficult to manage these patients. During my earlier involvement in this area, first I was always like most people think that it's better that a person has a quick pulmonary embolism and passes off, but I had to change my mind because the distress of that thing is very terrible, and so the approach was that to go ahead and give them anticoagulants, but then now we are talking about increased bleeding risk also. But personally, I feel that the distress of dying with a pulmonary embolism is much greater than the distress of bleeding, because by bleeding, they quickly go into syncope and loss of consciousness. So that is a easier way rather than the distress of breathlessness and dying. So personally, I would prefer to anticoagulate rather than worry about the bleeding, provided you don't use drugs like NSAIDs and things like that. So that's my thing, but I have no recent experience which I can share. Thank you.
Thank you, sir. A very important, very useful insight into what you feel about patients' distress, balancing the distress versus symptom presentation. And also, what a very recent study in 2022, in one article I saw, where they say that they randomly looked at the prevalence of DVT in palliative care patients, and they found that 20% of them, they had femoral artery thrombosis. They didn't have any symptom actually. So it is so common. So do we go on doing prophylaxis for all the patient or not is something we have to debate versus, but once it is diagnosed, do we treat or not, especially in palliative care, is something we have to, it's like always debated around. I'll come to Meenakshi, but before that, there's a question from Dr. BG. How often do we need to monitor PTINR in patients on anticoagulants in palliative care? My understanding is more for patients on who are on warfarin. Yes, Dr. Tendril has already responded. We need these monitoring for warfarin and heparin, but for other newer anticoagulants like which Arjun has described, or a direct oral anticoagulant and low molecular weight heparin, we don't need such kind of monitoring. So that's another reason that is much more preferred over the traditional anticoagulants. Dr. BG. Dr. Meenakshi.
Ma'am, good morning. Thank you, Arjun, for that clear presentation. I had 3 questions, ma'am. One is taking off from what Dr. Vijay and Dr. Tendril just said. The direct acting oral anticoagulant is very convenient, but if I'm correct, it is not recommended for primary prophylaxis. If the patient has a thrombosis and then we begin on low molecular weight heparin during the acute phase and then discharge them for a period of 3 to 6 months, depending on the risk, on a direct acting oral anticoagulant, that is correct. But for primary prophylaxis also, many people are using because of its convenience feature. But if I'm not mistaken, that is not cleared by all the guidelines. That's one doubt I had. Second one is,
we'll respond to this. Arjun, what is the consensus about as per the American Association of Hematology guideline? Primary prophylaxis.
Ma'am, like ma'am mentioned, with regards to primary prophylaxis, low molecular weight heparin is actually preferred over other agents actually.
Oh,
and
okay.
other thing like other thing which I would just answer is that most of the time it's preferred that we actually start on a drug which has got a better safety and efficacy profile, doesn't interfere with the chemotherapeutic agent rather than oral medication actually, just because of the convenience sake. That's what all the guidelines clearly mention actually.
Thank you. So it is low molecular weight heparin. Thank you, Meenakshi, for highlighting that. Yeah. Sorry, your next comment.
Yes, ma'am. That was the second question I have is to clarify for myself. If I have a patient who was hospitalized as an inpatient for any acute complications of chemotherapy and such, and then go on to become best supportive care where no disease-directed therapy is going to be continued, say a CA stomach patient, but whilst they are in the inpatient, they are receiving low molecular weight heparin. Now, this patient goes to the hospice. Now, am I to continue? But they have no evidence of DVT. They are generally immobile, mostly bedbound, PS3, PS4. Do I continue the anticoagulation when I shift this patient to hospice is my confusion all the time.
Arjun, do you have any recommendation which talks about this situation where they are on prophylaxis, but there's no evidence, and now they move to palliative care setup with very poor general condition?
Ma'am, unfortunately, there isn't any clear-cut guideline regarding the same actually, because most of the guidelines exclude patients who are in very poor performance status. But from the articles which I've read, what they generally say is that if the patient is in a very poor performance status or is in end of life, it's better to stop the oral anticoagulation, like anticoagulant agents, and to manage the symptoms with the palliative care medications as such, like giving proper pain medications or managing the shortness of breath as such, rather than continuing an anticoagulation is what a general consensus is there. But unfortunately, there isn't any clear-cut guideline behind this action. So we have to evaluate in a patient.
I will take one of those, your last comment on your presentation, that have a family discussion, have a patient discussion, and have a consensus around the withdrawal, considering quality of life versus unnecessary intervention. I think we should always, as a palliative care, we always do that, and that's always helps us in taking that decision. I'm sure Meenakshi, like you will also agree that better to have that discussion and take a consensus um, on what is a way forward, and that's something always useful. But having said that, even in home care setup, they say that patients, not if they're not very poor condition, but generally if they're really okay, expected a relatively longer life, that sub-Q medication of low molecular heparin on long term can, like 6 months if they require, it's quite acceptable even in a home care setting, they say, to continue on that. Yeah, sorry, Meenakshi.
Yes, ma'am. Thank you, ma'am. That was very helpful. Actually, regarding the post-thrombotic event that you mentioned, we had very recently a patient who had CA breast several years ago, and then now developed in the other side as well. And she had terrible lymphedema on the side, operated side, and the opposite side also she was having thrombosis, so much so she could not even lie down for any imaging. So it's all conjectural. We didn't have full imaging, but almost bilateral swelling of the upper limb, and that was the most significant distressing feature for this patient. Not her cancer, not the prognosis, but the fact that both the limbs were so swollen and heavy, the pain. And this patient actually was on apixaban, and we continued apixaban till end of life, even after shifting to the hospice. Using the logic that, there was a thrombus in place, and and there wasn't any bleeding manifestation. So we thought we'll just continue with the apixaban till the end of life. I don't know whether that was the correct decision or not, but that's what we did. I just thought I'll share. Thank you for the
Actually, we had comment about Dr. Burhanuddin saying that sometimes the chemotherapeutic drugs gets withheld because of negative outcome, and that delays the treatment. Yeah, totally agree with you. I see one hand, Dr. Shobha Nair. Please give your reflection.
Thank you, Gayatri, and thank you for that wonderful presentation. I just wanted to, follow up on Meenakshi's comment about whether should we continue prophylaxis anticoagulation. So I think in other countries, the practice is, if you are an inpatient and if your performance status is like 3, or you're like 50% more, or more of the time bedridden. So at that point in time, you might probably get discharged and go home. You never know, but you might be approaching your end of life care as well. In that scenario, it is a regular practice to put them on prophylaxis, like 2,500 or maybe 5,000 international units once a day, depending on the weight of the patient. And the two indications where we would stop that is probably bleeding from somewhere, including hematuria, and the other thing is the platelet count falling. So when once it reaches 100 and below, then we would stop giving prophylaxis. But otherwise, it's a norm in other parts of the world to give this prophylaxis, and we don't probably initiate this because it's going to be expensive and it's going to add on to the patient's burden. And the effect of that, I think, like Stanza said, the chances of the patient going into a pulmonary embolism and suffering due to that can be reduced. Although I'm yet to kind of read a paper, and maybe I need a thorough literature review about what are the advantages of putting these patients on prophylaxis, and Arjun probably has touched up on that. So I would like to say that unless and until, if you have the wherewithal to do it, I think it's a good practice to initiate a prophylactic anticoagulation and anticoagulating agent. And we always, as a community in India, we generally do not go forward to diagnose pulmonary thromboembolism. Again, because of the cost and cost for the CTPA, etc. And we would think that anyway, the patient is going to die. What are you asking them to spend this on? And we just do the D-dimer and then probably decide on that, okay, let's start this. And most of the time, the patients are not able to lie down flat in the CT scan area and things like that. So that again becomes difficult to actually diagnose a pulmonary thromboembolism. That's what I wanted to say. Thank you.
Thank you, Shobha. Tendril, Dr. Tendril, I see hands going up.
Yes, Dr. Gayatri, thank you for the excellent presentation. The thing is, I want to clarify, can we start people who have established diagnosis of DVT after they have been discharged as a cheaper alternative on oral warfarin? If that is the case, because when I discussed with my oncologist, he said, no, it has high bleeding risk. That's why we are putting them on apixaban. But the patient and a family member complained that it is costly for them. So if that is the case, how often should we do, once we establish the INR, can we maintain it at that, or how frequently should we repeat the PT-PTT INR for them, considering the cost factor?
So, Arjun, you want to respond to that? Suppose they are on warfarin, how frequently? That actual guideline, what does it say? Do you have any thoughts around that? Have you read about it?
Ma'am, with regards to warfarin, what the guideline actually suggests is that once the patient is discharged, it's ideal to stop the thromboprophylaxis is what the guideline suggests actually, ma'am. At the point of descent, you need not continue it is what the guideline suggests actually. The only time where they suggest on continuation of the thromboprophylaxis is that if the patient has underwent an abdominal or pelvic surgery actually. And both these cases, they suggest a directly acting oral anticoagulant agent over warfarin as such. So I would suggest once a week itself. Since DOACs are much more expensive compared to warf, it would be better to check it once a week. Like when we consider practical aspects actually. I would suggest that PT-INR can be checked once a week, but again, there's a stress of the cost of doing the blood test and taking the patient for that. So either we can stop it or they are continued on warfarin, we can do it once a week actually.
Thank you so much, Dr. Arjun.
Dr. Biji?
Madam, I just wanted to say what we practice in our place. First of all, Dr. Arjun, it was a very wonderful presentation. Thing is that when the patient has already developed DVT during the hospital stay, and now that the patient is not going to have any anti-cancer treatment, and he or she is shifted to palliative care treatment, and when they're discharging the patient, what our oncologist suggests is that we do not continue the parenteral anticoagulants. We start them on, we convert that to warfarin. So our oncologist, hemato-oncologist says to put the patients on 1 milligram warfarin with no monitoring of PT-INR, with whatever benefit they get for that. And I have not had any complaints after that, like any bleeding episode or so far, it's going on well. So that is what we follow in our thing. I don't know whether it is there in the guidelines or not, but this is what we follow in our institution.
Thank you, Biji, for sharing the experience. I also see Dr. Bayruddin saying that actually they're talking about deprescribing. More and more people are leaning towards that, actually deprescribing. I was quickly checking at warfarin, how frequently we should be doing it. They say starting with one to 2 times a week. And once the blood level reaches a stability, they say it's enough to do every three months warfarin. That's what they're saying. Any other comments? I see Dr. Seema Mishra here, and you must be seeing a lot of patients in acute post-op period and during perioperative period and cancer, and then you're called in to manage pain, palliative care concomitantly. Any experience you would like to share in acute care setup, hospital setup? What do you do?
Good morning, everyone. Like in perioperative care, this is a standard practice. All pelvic surgeries, we are giving the prophylactic doses and continuing the post-op period till the time patients are mobile. And you're able to hear me? Hello?
Yes, please. Yeah, go ahead.
I'm audible. Hello?
Yes, Seema, we can hear you.
Yeah. So in post perioperative care, all pelvic surgeries are going to be started on prophylactic 1 day before that prophylactic prophylactic dose, and it continues till the time patients are bedbound. Like most of the time, patients are 3 to 4 post of day, they are mobile. So they are going to be stopped. If they are not going mobile, let's continue to for another 1 week. And for rare cases, it can extend it up to the 4 weeks of the surgeries, the major surgeries, especially the high-pex surgeries and all those are there. Like in palliative care settings, what we do, whenever the patients are coming in the acute stage and they come with a very severe pain and a lot of swelling is there, we do get the Doppler done. And in that period for a week and so, obviously in such type of patients, we are giving injectable. But the same problem which everybody is facing, that cost factor is a major one. Once they're going to be discharged, it's very difficult for them to come daily to our hospital, which we are giving the free of cost. Though those are staying nearby, they're coming and they taking daily the injectable doses. But those are not staying nearby to our hospitals. They are not continuing. They can afford, then they're taking these injectable doses for 4 weeks at least. Otherwise, we are not really encouraging any patient to take that anticoagulant, frankly speaking.
Thank you, Dr. Seema. Very practical suggestions. Any more? I see many other seniors and those who are practicing every day want to share your experience. We still have a few minutes left. Jennifer, I see Jennifer. Your department practice, Vidya. Sorry, I'm just randomly picking up.
Hi, Gayatri ma'am. Thank you so much for that presentation. I just wanted to reiterate one thing, that when we are practicing early palliative care and concurrent palliative care, our index of suspicion also should be really high, because we should also be able to pick up thromboembolism early. So whenever patient complains of pain, so unless we know that, we have to look for this. So that's one thing I wanted to say. Another tricky area is dealing with bleeding and thromboembolism, because many of our patients with CS cervix and all of them, they land up with bleeding. So that's when we have to optimize what is going to give more benefit, and then choose the drug. So these are tricky areas, and yes, we do avoid NSAIDs in these patients. So thank you so much for that presentation.
Thank you, Vidya. So one take-home thing is that patients with the DVT, one of the cause of sudden death in cancer patient is DVT. That's something we have to realize. In palliative care, suddenly when somebody dies, we have to think about DVT. So we should have that clinical skill. People working in palliative care, all health workers, the skill to diagnose and carry that high degree of suspicion of DVT. And at the same time, we have to understand that many times when the patients present with symptoms of DVT and thromboembolism, often it is because of disease progression. So we should know, but carry the high degree of suspicion. Thank you, Vidya. We just have just 1 minute, 2 minutes left. Maybe we can, if no more comments, I want to hand over to the.
Just thank you, Dr. Gayatri and Arjun, for excellent presentation as well as excellent discussion, everyone, for contribution. I think it's an important topic, and I hope that whatever deliberation and whatever discussion we had, people must have learned a lot. So thank you very much, and see you next week before 6:30 on Monday. Thanks, Archana and Nisha, Gayatri and Arjun.